Good afternoon, everyone. My name is Rebecca Saltzbaugh, and I'm with the Christopher and Dana Reeve Foundation. I would like to welcome you to today's webinar on empowering women living with paralysis, breaking barriers to reproductive health. Thank you so much for joining us. Before we begin, I'd like to introduce our webinar presenters. Cody Unser founded the Cody Unser First Step Foundation with the help of her mother, Shelley Unser. After becoming paralyzed at 12 years old in 1999, due to the autoimmune disorder transverse myelitis, Cody has become a leading advocate for people living with disabilities and spends much of her time traveling across the country to deliver keynote speeches, attend medical symposia, and help other grassroots organizations that have missions similar to that of the Cody Unser First Step Foundation. She is passionate about the healthcare of women with disabilities and presents on this issue at grand rounds in medical facilities. Cody received her undergraduate degree at the University of Redlands in California and her master in public health at the George Washington University in Washington, D.C. Danny Izay is a disability advocate and wheelchair user. She is also one of only a handful of women living with quadriplegia known to have given birth to twins. Danny currently works full-time with Spinergy as a social media manager and advertiser, promoting their wheelchair and bicycle wheels. She holds a master's in English literature with a focus on disability studies. Her newest passion is elevating the voices of parents living with disabilities, and she is the subject of a new documentary film, Danny's Twins, about pregnancy and motherhood with quadriplegia during the COVID pandemic. Just so everyone knows, we do have closed captioning available. Just need to click on the little box that says CC down at the bottom of your screen. And if you have any questions for Danny or Cody, please feel free to enter them into the Q&A function, which is also located at the bottom of your screen. We will have time at the end for Cody and Danny to answer your questions. Thank you so much. And with that, I will turn the webinar over to Cody.
Awesome. Thanks, Rebecca. I just want to say thank you all so much for joining us. I know it's a Friday, but this topic is extremely important. And, we've been trying really hard to push and break down these barriers to reproductive health for women with paralysis and also with other disabilities. So I'm really excited to be doing this and also excited to do this with Danny. So thank you all for joining us. And we also want to thank the Christopher and Dana Reeve Foundation for this platform. It helps, keep our voices and faces out there, as this really is, this topic is really affecting millions of women in the US. So with that, we hope you, our main two goals really is to really kind of educate the medical professionals who are either participating in this conference, but also to really empower, motivate other women who, like us, use wheels, use wheelchairs. So it's the two goals are that. So we hope you enjoy the conference and the webinar. And if you have questions, feel free. So with that, next slide. So I know Rebecca just told you a little bit about myself, so I'll keep this brief. I was born and raised in Albuquerque, New Mexico. I grew up in sort of an auto racing family. So my childhood was, anything on wheels, whether it was four-wheelers, jet skis, anything with an engine, basically. So I spent my childhood kind of always on the go, living a fast-paced life. I played basketball. I loved gymnastics. And then on February 5th, 1999, my story completely changed. My journey changed forever as I became paralyzed due to transverse myelitis. It actually happened within 20 minutes. I was playing basketball and suddenly had a really hard time catching my breath. Felt like I couldn't breathe. So my coach said, "All right, Cody, just sit out." And the symptoms just got worse. I got the worst headache I've ever felt. The school called 911. They put me in the locker rooms and laid me down, and my left leg was really numb and my right leg was kind of tingling. So in a matter of 20 to 30 minutes, my life completely changed. I became paralyzed. So my journey kind of continued with that in the hospital. And then after that, rehab, which a lot of us with spinal cord injuries are very familiar with. No matter what injury you do attain, or even other disabilities, you kind of learn how to live your new life in rehab and any rehabilitation center. So those were definitely the darkest days, I will say, because everything surrounded, by the wheelchair. Everything was about transferring my new paralyzed body in and out of the chair, learning how to dress myself, bathe myself. So it was really frustrating, a lot of angry moments. No one told me that rehab was about the wheelchair and my, newly paralyzed body. I thought I was going to walk again right from the get-go. So it was a big shock. And I thought, okay, well, if I have half of a working body, then I'm only going to really experience life half. I'm not going to have a whole life. I really thought life was over. Like, there's nothing out here for me. And then that's when, after I came home from rehab, my older brother Al got me into scuba diving, which changed my life forever. And my mom and I started the Cody Johnson First Step Foundation. So we work a lot about advocacy, awareness, quality of life. Scuba diving is my passion, so I try to help other people with disabilities, get back into life by using scuba. And then lately, sort of my passion has now been into really educating medical professionals about the needs and barriers for women with disabilities, because this is a topic that's really affecting a lot of us women. So I'll get into a lot of that, but this is just a little bit about me. So next slide. So I usually, when I present this talk to OBGYN residents during grand rounds, I usually have this slide at the end, but I decided to put it here at the beginning because I think it's extremely important for all of us to put in the back of our minds throughout this webinar. So my prescription to the problem around accessing sort of our reproductive health care is that there needs to be more integration, better accessibility, and we need to improve the quality of care. And I think I think the problem really lends itself to the solution, which is really education. I mean, there's not one disability course in medical school in the US, anywhere, that just teaches the basics so that anybody in medical school who goes on to teach or be a physician in any field, or even a nurse or anybody in the medical profession, will actually just have the basics. So I just really kind of want to let everybody know, we're trying to encourage the removal of physical and attitudinal barriers for women with disabilities, really encourage more education and dialogue amongst healthcare professionals and patients. So this is really sort of the prescription to the problem. Next slide. So I kind of wanted to also throw this out here as well. So there's a new study that just came out this year in February, and it's, everybody with disabilities has known this for years, about sort of not only the physical barriers, but also the attitudinal, educational barriers, the biases that physicians have, whether they know them or not. And this study was kind of interesting because I think due to social media, a lot of people actually found it interesting. So the study was done. They surveyed about 715 physicians across the US about their sort of perceptions about treating people with disabilities. And what they found was that more than 82% of physicians in the US believe that people with disabilities have worse quality of life than people without disabilities. And why does this matter? Well, how a physician perceives you is really how they treat you or examine you. So even if they're not even aware of it, right? We all have our own assumptions, biases in society about anything and everything. So even if you're not aware, actually what you say and how you act really does affect how a physician is then going to treat you in the exam. Another fact that I kind of wanted to say is that we are heavy utilizers of the healthcare industry. I think we're probably the largest population in the US, maybe even the world. People with disabilities are heavy utilizers of the healthcare industry. And it's interesting that everywhere else in society, when it comes to access, we seem to sort of adapt well. But when it comes to healthcare, suddenly we run into so many barriers, and it really shouldn't be this way. We really want to take care of ourselves, be independent, live the best lives that we can. And we want to work with physicians And I know there's a lot of biases out there, but it's really something you should pay attention to as well. Next slide. So I kind of wanted to, I think a lot of where physicians are at and where society is at, I think, is stemming from how we have evolved from understanding as a society about disabilities. And there are two competing sort of theories that kind of contradict each other, but they really have shaped how a lot of us think about disability in general. So the first one is the medical model, which is really the whole traditional thought about fixing someone, curing someone. A lot of people with disabilities, we look deformed, we're sitting in wheelchairs using canes or other mobility equipment. So we look sick, right? So the whole medical model is really about addressing our population, but really just about fixing and curing us. There's something wrong with us. Disability is first and foremost a medical state, emphasizing physical, intellectual, sensory, neurological, or psychological difference. Really, so the emphasis here is about the individual's functional limitation. We got to fix this person in order for them to have a great quality of life, right? So that's the medical model. The social model, which is where we're trying really to move towards, is basically saying that disability is an experience, and it's really a response, and it's created by social responses to beliefs regarding and accommodations for people with impairments. So the emphasis here is mainly about addressing societal norms, beliefs, practices, adaptability, interaction with the environment. So kind of like how the picture on the right side depicts, the medical model is basically saying, all right, so the person in the wheelchair, in order for them to get up the stairs, we need to cure them. We need to make them walk again. The social model is saying, no, they are fine the way they are. We need to put in an elevator or put in a ramp, make the environment around them more accessible and adaptable for that person. So these are the two competing theories that have really shaped where we are today. So next slide. So just to give you guys sort of an overview, kind of like a snapshot of women with disabilities in the US, a lot of the research that I did kind of showed what we look like. So there's approximately about 28 million women that are living with some form of a disability. And the more common forms that we see are arthritis, neuromuscular disorders, multiple sclerosis, stroke, spina bifida, cerebral palsy, spinal cord injuries. Compared to women in general, women with physical disabilities are more likely to be single, have less than a high school education, be unemployed, live in poverty, and have inadequate access to healthcare. And I will say that a lot of research is very limited, right? Disability is not a sexy topic for researchers, but the studies that I did find, they did say that, consistently show that women with disabilities have poor health compared to women without disabilities. And this is especially when it comes to their sexual and reproductive health. So here's just a snapshot. All right, next slide. So if there's one thing that I think Danny and I would love for all of you to take away from this is that the sexual and reproductive health of women with disabilities does matter. We do matter. And health really starts from the context of which we live, right? So kind of how the pink circles on the right side are depicting, it really begins with self-awareness. And I will say that it's really hard to advocate for yourself. It's really hard to, you don't want to sound condescending to either physicians that you know too much about yourself, but in reality, you are the only one that knows. You're the expert on you. So it really begins with self-awareness. And then from there, kind of the relationships that we have, our family, our friends, our loved ones, intimate partners, and how our own self-awareness and our relationships can help build more of a better improvement in quality of life. And then from there, where's the environment in which we live? Like, how do we work? Where do we work? Where do we live? What do we do for fun, recreation? So all of these three things really do, kind of depict how we live and, the fact that we want to be independent and to have a great quality of life as much as possible. So kind of going further into this, So when it comes to the reproductive health of women, we have to talk about the pelvic health, which includes the bladder, the bowel, and the organs of reproduction, which then include the ovaries, the uterus, the cervix, the vagina, and the external genitalia. All these things really do affect our overall physical, mental, social, and sexual well-being. I think for a lot of us women with disabilities, we deal with a lot of bladder and bowel issues, right? So when it comes to our sexual health, it definitely does sort of affect, it comes into play. Like I can't tell you how many times I've had a bladder or bowel accident during sex, and it's embarrassing. You don't know what to do, but you want to be able to talk to a physician or provider about it. Like how can I prevent this from happening? So it really does affect our quality of life. Next slide. Which leads me to sort of talk about secondary conditions. I don't think we talk about them enough, especially to our medical professionals, even to my dentist or my primary care physician. I try to really give a whole description of what paralysis is. It's not just me being paralyzed, not able to walk, and I'm sitting in the chair. It actually has a whole host of issues called secondary conditions. And what these are they're medical, physical, cognitive, emotional, or psychosocial complications of a primary disabling condition. And all of these really do impact our daily activities and quality of life. And I think everybody has their own spinal cord injury journey, paralysis journey. We all have our own story, and which makes sense because we all sort of have either all of these secondary conditions or a variety of them or at different levels. But it is really important to educate our medical professionals and providers about the ones that we actually do have and are concerned about. So the list includes anxiety, arthritis, autonomic dysreflexia, which I'll get to here in a second, blood pressure problems, bowel and bladder dysfunction, circulatory problems, dehydration, depression is a big thing, diabetes, dietary specifications, fatigue, heart disease, mental problems, osteoporosis. Actually, in 2005, it was right before I was going off to college in California. I was sort of play wrestling on the couch with a friend, and my left femur snapped in half. I didn't feel it, but I definitely heard it. So I didn't realize how far my osteoporosis was from not standing and bearing weight. So really, I mean, all of us, osteoporosis is a really big thing. So now I have a titanium rod in my leg. I was scared out of my mind, thought that they were gonna have to amputate my leg off. But it is a really big issue. You know, if you transfer wrong or if you fall, you know, getting into the shower, it's something that we have to constantly be aware of. Overweight and obesity is a really big issue. It's really hard for a lot of us with disabilities to work out. Like a lot of gyms aren't either accessible or it's hard to find a trainer that will work with you. So really, you know, watching how you eat, even just going outside and as much as you can, do as much as you can really to kind of watch out for the overweight and obesity issue. Pain, a lot of us deal with nerve pain in various different ways, range of motion, regulating body temperature, respiratory issues, sexual dysfunction, skin breakdown. I have a sensitive spot kind of on my tailbone that kind of opens up occasionally if I'm sitting too long or if I'm traveling too much. And it's something I definitely want to watch and look out for because I could end up in wound care and in the hospital. So we're always constantly having to watch, you know, our skin for sure. And especially if you can't feel a certain area. Sleep disorders, spasticity, substance abuse, and weakness. So these are sort of secondary conditions that I think we need to talk more about. Next slide. So, which leads me to talk about autonomic dysreflexia, which I think is probably the most crucial one of them. If I were to meet any provider, which is why I've listed the entire definition. So autonomic dysreflexia is a potentially life-threatening medical emergency that affects people with spinal cord injuries at the T6 level or higher. Although rare, some people with T7 and T8 injuries can develop AD. For most people, AD can be easily treated as well as prevented. the key is really knowing your baseline blood pressure, triggers, and symptoms. So when triggered, AD requires a quick and correct action, or there may be serious consequences such as a stroke. So a lot of healthcare professionals are not familiar with this condition. It is very important for people who are at risk for AD, including the people close to them, to recognize the symptoms and know how to act. So the way I like to describe it is it's my own body's alarm system, right? So I kind of how the picture on the right sort of displays the guy on the, ticking time bomb. It kind of feels like that. Like you're constantly aware of your body, your surroundings, your situation. And it's literally your body telling you that something's wrong, you got to fix it, or else it'll escalate into a larger problem. So this is something definitely we need to educate our medical professionals on as well. Next slide. So kind of discussing sort of the causes of autonomic dysreflexia. So autonomic dysreflexia, kind of like what I just said, is caused by something that your body's not aware of. It's caused by an irritant below the level of injury. So I'm paralyzed kind of chest lying down. So anything that happens to my body below that level of injury, my sort of signs are I'll get either flushed in the face, I'll get goosebumps really quickly. Also, I might spasm out of nowhere. And a lot of some of the causes are when it comes to the bladder, kind of the irritation of the bladder wall. A UTI can really make my body go haywire. And that's when, I realize, okay, I check my body, make sure everything's okay. All right, it must be a UTI. My urine's looking a little dark. Now I need to fix that. Even a blocked catheter or overfilled collection bag can cause AD. Constipation can cause autonomic dysreflexia. And then when it comes to sort of our sexual health, definitely sexual activity can trigger your body's alarm system. So I know it's a temporary activity. So I know, all right, I'm getting flushed in the face. I'm getting goosebumps, but I know this activity is not going to last long. Now, if after I have sex, those, signs don't go away, maybe it was a little too rough, or maybe something's, wrong. So I kind of have to monitor afterwards, and then days afterwards, like if the signs really don't go away, there's something really wrong. So that's why you have to call your OBGYN and make an appointment, and you want them to know what autonomic dysreflexia is. So I know it's a temporary activity. That's why I also can't use tampons. My body's it responds really negatively. So it's something to be aware of as well. And in fact, a cold speculum can cause AD. So when I was doing my research, I read a lot of stories from other women, and this is one of the things that they noted definitely. And I don't think any woman would want a cold speculum during an exam at the OBGYN's office, but for women with disabilities, especially paralysis, especially those that are at risk for autonomic dysreflexia, it really can trigger your AD. So what I do every single appointment is they do take your blood pressure before. That's pretty generic. But I definitely say, can you please take my blood pressure afterwards, after the exam, so that I know if there's a big difference, I need to wait a while, or something might be wrong. Something went wrong with the exam. So it's something that we constantly have to be aware of, but our medical professionals and providers really need to be aware of them as well. Next slide. So when it comes to sort of how society has visioned or think about women with disabilities, it really does affect how providers, see us as well. That kind of goes with the whole medical and social model that I talked about, and also that new study about, providers, physicians' perceptions of us. And really, this has been an evolving kind of thing. Women with disabilities were either viewed as broken vessels, right? We're fragile, we're unworthy, or we're also listed as a fetish or on someone's bucket list. Like, oh, have you done the parachick? It's really talked about like that in bars and restaurants. So it's also the way we think about this comes from our historical how we've dealt with people in the past. So we've thrown people into institutions, right? So people with disabilities, this is why the whole disability rights movement was so important and so huge, is because we were wanting to be out in public, wanting to be independent and in control of our lives. So this is definitely an impact and an indicator of how we have thought about people with disabilities in the past. We just literally, it's a burden on society in every aspect, in every way, including the healthcare system. So when it comes to sort of how society views women, there's a whole other side of that as well, kind of who is beautiful, who is not. I think the fashion and beauty industry kind of do that very well. But for women with disabilities, like we go through, our legs are atrophied, or maybe our, depending where our paralysis level is. So we want to be sexy too. And it's hard to find, and this comes into the dating world and conversation, but it's really hard for us to feel beautiful for ourselves within ourselves, because society has it in the past and still sort of doesn't. But we went from being institutionalized to then becoming more of a socially isolated group. And then from there, one of the largest minority groups that anybody can join at any time. You can become paralyzed at any time. And then now, like, the cool thing is, like, we get to talk about sexuality and reproductive health care, and really advocating for our healthcare professionals to really learn and treat us how, like any other patient. So it really stems from an historical perspective, sort of how we've evolved in thinking about women with disabilities. All right, next slide. All right, so discussing a little further about sexuality for women with disabilities. Women with disabilities, we can lead loving, intimate, and fulfilling sex lives. This has been a taboo. It's assumed that we don't have sex, because it's too hard or too challenging, depending on, our paralysis level. So society in general views us as this, but then sort of the healthcare professionals do as well, right? So we're often seen as asexual. And I did have one experience with my mom, who I had to take to my OBGYN appointment because I knew the barriers were going to be there. I knew she was going to have to help me on the exam table, but we were in the exam room. The nurse, she took my vital signs, and then she left the room and kept the door a little cracked. And I remember hearing the nurse tell the physician, "Oh, by the way, she is sexually active." As if, the provider coming into the room and seeing me in a wheelchair, she would have thought that I wasn't sexually active. So it was very, and it's just frustrating that you're viewed as something that you're not. And you want to learn as much as possible about your life so that you do and can lead a loving and intimate, fulfilling sex life. Just because there is a lack of function or sensation, it just means that couples have to get more creative and develop more of a connection and an intimacy at a different level. So just don't, what I do have to, caution you about is, because I do have osteoporosis, I definitely have to be careful on how creative you do get, right? So here comes sort of the secondary conditions that we all sort of deal with. Some of the common sexual dysfunctions for women that we do see are pain during sex, lack of interest in sex. A lot of women aren't able to feel anything. So it's really creating a different level of intimacy. Trouble with lubrication. I take some medication to help with my bladder control, and that causes dryness in my mouth, everywhere else. So it'd be nice to talk to a provider to figure out, what are my options. Lack of pleasurable sex and inability to achieve orgasm. So these are sort of the issues, the most common sexual dysfunctions that we see. Next slide. So talk about the sexual response. I don't know why that picture on the left isn't showing up, but it really is just kind of showing you the traditional model of the sexual response, which is sort of desire, when we connect with a partner, and how it kind of goes up and then plateaus down, and resolution after orgasm. But for a lot of women with disabilities, the sexual response is more kind of like a Jackson Pollock painting. So this is, again, where the secondary conditions come into play. So we're constantly sort of worried about a bone fracture, pain, anxiety, am I gonna have a bladder or bowel accident, spasticity, that's a really crucial one, lubrication, and again, like I said, bladder and bowel accident. So the sexual response for women with disabilities is completely different than the traditional model. So it's really kind of, I think, valuable for OBGYNs to sort of pay attention to this and sort of work with their patient to figure out how to work through all these issues. It's really important. Next slide. So what are the barriers to quality of care? So I'm sure Danny's going to talk about a bunch of them as well. And I'm sure a lot of you women that are watching this presentation, you deal with barriers all the time. But when it comes to sort of accessing, our reproductive health, there are two barriers that I've noticed throughout the entire country that are really significant. One are the physical barriers, right? So these are they're structural in nature. So can we actually get into the clinic? Are the doors accessible? Is there an accessible button that I can push? Are the bathrooms accessible? That's also really crucial. Sometimes, I think most of the time during an exam, you need to provide a urine sample for your provider. So being able to transfer safely onto the toilet if you need to, grab bars are really important, especially for those of us who spasm every time we transfer. Those bars have really come in handy. And then the major problem that I think a lot of us know very well, and this is a problem that I think kind of is throughout the entire healthcare system, really. It's not just, our reproductive healthcare system, but primary care physician offices, even, like I said, dentists. You wouldn't think the exam room table, anything that you need to transfer onto should be accessible. And we're trying to get there. But the problem with the ones that we have now are they're too tall, they're too narrow. So if you do spasm, if you transfer, you can fall off. So it's a liability as well, but also a safety problem. And the other main thing too is for a lot of us, we don't get our weight calculated. I haven't had my weight checked in so long because there's no scale that's accessible for us with disability. So, and weight is really crucial. It's a crucial indicator for any sort of health problem that you have going on, or not only that, but medications, right? Dosage. It really depends on how much you weigh. So there are a lot of different accessible exam tables out there that actually have a scale built right into it. So the exam room table is probably the biggest problem that I think we all sort of face. And it's really important to not only feel safe and secure, but also to give, a proper and whole exam with the provider. So this is a big problem that I really don't like. All right, next slide. All right, so the second barrier that I think a lot of us also run into, and I sort of addressed it in the beginning, was basically the attitudinal barriers. And these are behaviors or perceptions that prevent people from communicating. It's really a lack of understanding, sensitivity, knowledge of providers that really can lead to incorrect assumptions and discriminatory statements. So if you have a provider that thinks or assumes that you're asexual or you don't have sex just because you're paralyzed, they're not really going to go into other aspects of care, right? They're not going to talk to you about contraception. They're not going to talk to you about family planning if you want to be a mom someday. So they're really going to hold back just based on that one assumption. So we definitely want to encourage the provider to learn about our conditions, right? It's upon us, unfortunately, to really, as much as possible, and give as much as possible your medical history. Bring a pamphlet or a brochure. I always bring my transverse myelitis brochures. I always carry the autonomic dysreflexia wallet cards that the Reef Foundation provides. And, I think if you put the knowledge in front of a provider, I think they might be more willing to discuss sort of your care. instead of, them having the option to say, I don't know, let me look into that. You're kind of giving them the keys, basically. So really, I'm just really encouraging everybody, really be specific on your medical history, including the management of different medications, your daily bladder and bowel routine. If you do cath, how much do you cath? And of course, your sexual history is really important. So again, the more you share about you, the more you receive. And another thing I will note is that one size does not fit all, right? We all don't have the same paralysis journey story. Danny and I obviously are very different. I'm a paraplegic, she's a quadriplegic. So we definitely have different issues. So you definitely want to give the provider as much knowledge about you so that they don't assume anything about you. So it's really important. All right, next slide. So what are some of the consequences of these barriers? I will tell you, I'll share with you sort of an intimate story. I was going to school in Washington, DC, and after numerous providers and offices that weren't accessible, like one office, there were immediate stairs down into the clinic. They didn't even have an elevator. I then actually found a provider because I was dealing with a really bad heartbreak. I was really heartbroken after a 7-year relationship. So I really just kind of gave up on myself, started drinking too much, having too many sexual partners, and just really, I gave up. I didn't, heartbreak is really hard. Being heartbroken is really hard. So I woke up one day and was like, you know what, this is not how I want to live my life. I'm better than this, and I want to take care of myself. So I found an OBGYN. And after really explaining to him, I have transverse myelitis, I'm paralyzed, I'm an incomplete paraplegic, I will spasm on the exam table. After going through all of that, he sort of reached over after, putting the speculum in, because I started spasming, like I told him would happen. And he sort of, kind of patted me on my leg, which I didn't feel at first. But he said, oh yeah, it's okay, don't be nervous. So I felt, I'm not nervous. This is just what happens, like I just said to you. So I do understand the frustration. Even if you do explain absolutely everything, providers still will feel, or you don't feel heard, right? So unfortunately, it's kind of like dating or auditioning somebody. We have to go through so many different providers to find the one that we can actually jive with and that gets you, understands you, hears you, and we'll look into, okay, so you have transverse myelitis, and we'll actually go and research that. But I left that office feeling, all right, so if he doesn't care, why should I? I wanted to, I call my mom crying because it really does affect you. If you don't feel heard by a provider, then you kind of just want to give up and not care either. So these barriers do have consequences. So women with disabilities are more likely to experience diagnosis delays of sexually transmitted diseases, breast cancer, or cervical cancer. Women with disabilities are less likely to have preventative screen tests, including mammography, pap smear, and HIV testing. Women with disabilities who feel defeated or rejected by an OBGYN will not care for their bodies. They will engage in risky behaviors such as multiple sex partners, sexual abuse, and violence. So these barriers do have consequences, and we need to really try to fix them as much as possible. Next slide. So here's some tips for women with disabilities. These are the sort of the two different ones that I have. So when it comes to physical accessibility, call the OBGYN clinic and ask these questions. Is the parking lot accessible? If you drive there by yourself, or even if you go with, a friend or a loved one, you definitely want to know what the parking situation is. Can I get into and around the clinic? Are there any steps or stairs? Sometimes you have to be really specific about not only get around, but what does that actually mean? Is the bathroom accessible? Again, is the exam room accessible for me to transfer onto? Or can I bring somebody to help me? Does it raise up and down? Because a lot of people, they don't know what accessible means. So you really kind of, again, have to be specific. One thing I do realize or have realized, one of the biggest tips I do have is if they say that they don't have, an elevated exam table that goes up and down, ask for the procedure room, which actually does have an accessible exam table. So these are sort of the list of questions that I have for women with disabilities and sort of the tips around physical accessibility. Next slide. So when it comes to sort of addressing the attitudinal barrier part, the patient provider communication, these are sort of the tips that I've sort of developed that I hope might help. Really at each step, you have to provide the healthcare team your complete medical history and needs. So even just calling the clinic, you're going to get, the receptionist at the desk, and that person's not, you're a stranger to them, obviously, but you really have to dictate and advocate for yourself about your needs and say, describe yourself. I am a paraplegic woman. I want to come in for, my annual exam. And go through those list of questions. Is your clinic accessible? Do you guys have an exam table that's accessible? If not, can I bring somebody in? Unfortunately, we have to navigate this concrete jungle of a world we live in, but it really does help. Really provide at each step all of your medical history and your needs. Don't be surprised if providers have assumptions or sort of ask dumb questions. They just don't know. They didn't have the education in medical school. So it's hard to not get frustrated, but just realize that, all right, I'm going to have to really sort of express my entire medical history, but just don't get frustrated too easily. You can work through these communication problems. And we do this throughout society in general. So again, you are the expert on you. Be open and honest. Take someone with you if you need to, not only to help you onto the exam table, but if you need that like sort of emotional support. I know family members can be advocates for people. My sister Shannon, definitely, she becomes a little more vocal than I do. So I know family members are very, they can help as well. So again, the more you share about you, the more you will receive, hopefully. All right, next slide. All right, so for my last slide, before I turn it over to Danny, and I try to be fast throughout this presentation, there's just so much information, and it's important, it's really crucial. So here's what the ideal OBGYN experience looks like for women with disabilities. So I begin with sort of a picture of wheelchair Barbie, but really, again, it's all about self-awareness, really just empowering yourself, not giving up. Like if you go to one provider, the clinic's not accessible, the provider didn't hear you, or even the nurse didn't really understand. If you just feel there's not a good vibe, don't give up. There are providers out there, right? It's just like dating. You have to sit there and find somebody, and it's a lot of work. It's overwhelming. This is where friends and family really can help. So self-awareness, we want to be independent. We want to empower ourselves. And then of course, accessibility into the healthcare clinic. This is ideal. I would love to be able to just call any OBGYN, make any appointment, and be able to roll right in. Unfortunately, we can't do that, but that's ideal. The elevated exam table, which really does allow for comfortable positioning, not only for the patient, but also for the provider. If the provider does care about doing a really good exam, he wants you to be comfortable. He or she wants you to be comfortable. So, and for a lot of us women, I don't even use the stirrups. I just hold my legs up. So it's really about knowing so much about yourself and being able to express that open and honestly with the provider. But the exam table, ideally we would like it elevated so we can transfer on to it by ourselves. It's a dignity thing as well. And then of course, sort of the knowledge and attitudes that providers have on my condition, having no assumptions about sexual history. I think that's the number one issue for OBGYNs, is having zero assumptions about your own sexual health, your own sexual experience and history. which then can lead to talking about contraceptive use and other topics, you know. So this is the ideal experience. And now I would like to sort of turn it over to Danny, who talks about pregnancy issues and, you know, her story, which I think is awesome.
Thank you, Cody. That was amazing. So informative and so much like concrete information for us.
It's a-
No, it's great, and I really like that little tip about the what the table. If there's not like a table in every room, you ask for the
procedure room.
procedure room. Right.
Yeah.
I have to write that down.
Yeah.
Okay, so I am here to talk a little bit about specifically about prenatal care for women with spinal cord injury or paralysis. Can everyone see the slides? Yes. Okay, so there's me, and there are the babies about 9 months ago, I think, Lavinia and Georgiana. You can go to the next slide. Okay, so my name is Daniela Isay. I go by Danny. I'm a quadriplegic woman. I had an injury over 10 years ago. I had a freak accident where I slipped and fell in a bathroom and broke my neck. It was also very sudden. I was instantly paralyzed. And it was, I'm not gonna lie, it was a brutal adjustment. It really was. And it took me years to adjust mentally and emotionally. And physically even. So, but you know, a lot of time has passed, and I dated people, and I did all kinds of fun, adventurous things, and then finally I met someone and got married. My husband, his name is Rudy, and we decided about 2 years ago now that we should start talking about having kids. And at the time, I wasn't so sure. I was like, okay, as a quadriplegic, I can hardly take care of myself. How am I going to take care of a baby, right? So I had a lot of insecurities about it, even though like one of my deepest desires in life was to become a mom. So I knew that when I first got injured, in the back of my mind, I was like, I need to make this work. Like I need to adapt because I want to be a mom someday. So it's amazing how like that the power of wanting to become a mother can like push you to overcome so many odds, you know. But anyway, I ended up having, when I didn't find out I was pregnant with twins, which was completely unexpected. I didn't have anything in my history or genes that predisposed me for having twins, and I didn't have IVF or anything like that, so it was random. But the reason I love sharing my story is because I think it's really encouraging for other women with paralysis. You know, they might have faced the same insecurities I had. But when they see this other woman who's a quadriplegic, me, that had two at the same time, I feel like that maybe might, ease some of their anxieties and be like, okay, that's pretty reassuring. If she could have two, maybe I could have one, right? So, so for that reason, I think it's an important story to share. And I also think I really want to impact the healthcare community and doctors and medical professionals. I want them to strive to offer inclusive and barrier-free care. Next slide. So let me give you a little snapshot of my prenatal care that I had. Like I said, I consulted with a high-risk obstetrician in May 2019, prior to even conceiving. And that was because I wanted to address some of my insecurities, not just emotionally, but I wanted to talk about if my body could handle carrying a pregnancy as a quad. So I made an appointment and I had this consultation. And it was really positive. In fact, my whole experience, all my prenatal and perinatal care was remarkably positive. So I just want to put that out there. And that's not the case for everybody. But we can use my story as an example of what we can aim for, right? So my husband and I started trying in August, and we immediately became pregnant. 2 months later, I think it was 2 months, is when I found out there was actually two. Um, and, it just so happens that I was lucky that I was being seen by the high risk OB, because multiples pregnancy, which means more than one baby, necessitates high risk obstetrician. And actually, spinal cord injury, I was told by my doctor, does not necessarily necessitate a high risk obstetrician. Even though there are some risks involved, they are manageable. So if there is a traditional OB who has experience or confidence to care for a woman with paralysis, then that's an option too. So that's what I learned. I received my prenatal care from UVA Health here in Virginia. And like I said, I went to a high risk clinic. They also had a top tier NICU. And that was great because I did end up going into early labor at 34 weeks, which is kind of to be expected with a multiples pregnancy. So I'm really glad that I had that fantastic NICU right there. I ended up needing to have an emergency C-section. It went really well. And this whole story is documented in the upcoming film, Danny's Twins. So I was filmed, and I filmed myself during the pandemic and through my pregnancy, and it was wild, but hopefully it will be out in the winter, fall or winter, and I'll update all of you with that. Next slide. So here's some of the barriers in prenatal care, even though I didn't really experience that many, but here's some that I've identified. Next slide. Okay, so Cody talked a little bit about this. Well, I don't think she mentioned ableism precisely, but ableism is sort of a recent term, and it describes the discrimination. I mean, it's a recent term for something that has been around forever. So it's the discrimination of and social prejudice against people with disabilities based on the belief that typical abilities are superior. It includes harmful stereotypes, misconceptions, and generalizations of people with disabilities. And so the question we ask is, what are the origins of these ableist attitudinal barriers? And Cody already outlined it with the medical versus the social models of disability. Now, the medical model is just so happens to be the model that doctors, rightly so, are used to, right? I mean, they see disability as a medical issue, and in one sense it is. But disability is a kaleidoscope of things. It's not just that one thing. And with the social model, there are, society is what kind of shapes the disability. So society can either make things easier and make a welcoming environment that makes your disability not pose an issue, or it can make a hostile environment where your disability stands out and is a burden or an issue. So when we take both these models and look at them in the negative light, it's a massive attitudinal barrier, and it reeks of ableism. And unfortunately, ableism just sort of naturally pops up in the medical world and in reproductive care. So here's some examples, and this does happen. So medical professionals who suggest sterilization or getting your tubes tied due to the assumption that the patient is not fit for motherhood based on the disability alone. Just disability, and maybe not even for medical reasons. They just assume that, disability is bad or means that the person might be incompetent. So of course, these are just stigmas and myths. Some doctors have discouraged disabled women from conceiving. Some doctors have instilled fears in women with paralysis about the risks involved, but sometimes that just reflects their lack of knowledge. They just don't want to admit it. And also, some doctors will just flat out refuse to provide prenatal care because they're uncomfortable with it. I want to read a quote from a friend. I'm going to keep it anonymous, but this is what she said recently. And this is the kind of stuff I see all the time in my women's groups, my private support groups I'm in on Facebook, groups that are specifically for women who will use wheelchairs or have spinal cord injury or paralysis. She said, yesterday I got a call from the OBGYN that I had wanted, and she was extremely blunt and negative about the thought of me carrying a child. Talked about my lungs, that I can't feel, medications, blood clots, etc. These are all things that I know I have learned over the years could be a potential risk factor. But the way it was worded just completely broke my heart. I currently am weaning off my medications with my doctors. I know that if my husband and I don't carry our child ourselves, that we wouldn't be able to have one biologically. We just can't afford to have a surrogate. I'm feeling really down today and at a loss of what to do. This is something I've always wanted to do, and I feel like I'm strong enough to do it, but I'm feeling heartbroken now. So luckily, the women who chimed in and talked to my friend were all women who have had children and told her, reassured her, look, this doctor doesn't know what they're talking about. So don't worry, find someone new. Next slide. So knowledge barriers from doctors is another type of barrier. And these are two quotes from my amazing OB. Like, he was just the coolest person ever. His name is Dr. Robert Fuller at UVA. And he said, there often is a lack of knowledge, but it's the lack of experience that's the biggest contributor to the barrier. Now, this guy, he's a high-risk obstetrician, and one of the questions I asked him before he became my doctor was, I said, how many women with mobility issues have you treated? And he said over a dozen. So I do think the experience contributed to him being a great doctor. He also said, in terms of being advised to not have children, we do know there are some medical conditions that are very dangerous for women to have, which their life is at risk anytime they ever become pregnant. It turns out that a spinal cord injury is just not one of them. Okay, so if a doctor ever tells a patient that they shouldn't have a baby because they have paralysis, well, they're wrong. Next slide. Prenatal care options, by the way, that's me they were checking the baby's heartbeats. I think I went in for a little checkup. Okay, next slide. So as far as I know, I'm not super knowledgeable on all of this, but from what I've learned, these are the options you have. When you want to have a baby, you can go to a traditional OBGYN. You can go to a high-risk obstetrician, which is also often referred to as a perinatologist, because they also aren't just taking care of the mother, but sometimes they're dealing with complex pregnancies or babies that have genetic conditions. And you can find these subspecialists at maternal fetal medicine clinics or specialists. So a lot of women will ask me, like, how do you find a high-risk doctor? And I say, just Google maternal fetal medicine in your area and see what comes up. The other option is a certified nurse midwife. I know nothing about this, but I do know some women, lower level SCIs that had a midwife and had kind of more of the quote unquote natural birth experience. Next slide. So the reason I chose my doctor, obviously, I had to have a high-risk doctor because of the multiples pregnancy, which is considered complex. I also had an entire team. So that's the thing about going with a maternal fetal medicine clinic is you will have an entire team. And Dr. Fuller was sort of like, I kind of chose him as my main guy. And he kept everybody else really well informed. But I did see several doctors over the course of my pregnancy. And that was important. They all needed to know about me because they were all involved. And they were all contributing their expertise. And I didn't know who was going to get me when I eventually went into labor, so I needed them all to be ready and prepared. I also liked that there was a university affiliation. To me, that gave me more assurance and gave them more credibility. I liked that there was a level 4 NICU. That's the highest level, I guess, that there is. Other qualities I really liked was, just my doctor's personality. Really, like Cody said, it's like choosing a doctor is like dating. Like you have to find the right match. And my doctor I really appreciated his attention to detail. Now, that's important for any patient, but for a patient with secondary conditions and a chronic disability, it is so important because I had so many different things all tied together that needed to be paid attention to. I have my bladder health. I have the Mitrofanoff, which is how I manage my bladder. I have, blood pressure issues. So that was sort of something that needed to be talked about with the sorry, I'm blanking, the person that gives you the anesthesiologist, right? So I did appreciate that he was very attentive to detail. Next slide. Perinatal care is the care like just before you give birth, during, and right after. Next slide. That's a picture of me, by the way, right after the C-section. There's my husband. He was in the OR with me, which was great. And those are the two babies. Oh, that was an amazing moment. Okay, next slide. Okay, so for perinatal care needs, this is where it gets kind of complex. Now, most women create what's called a birth plan. And I think that the birth plan is possibly even more important for women with paralysis. Because a birth plan can be a document that you print out and hand out to your team, right? Or to your doctor. And it can have all the things that I'm about to talk about, all these considerations. You want to outline what you want. So not just like if you plan on breastfeeding or not, if you want a lactation consultant, if you want a C-section or a vaginal delivery, all those preferences that women have. But also for us, it's going to be things like, are you going to have access to your caregiver? And at what points will you not have access to your caregiver, right? So in labor and delivery, and especially during pandemic, that was kind of complicated, but when I was pregnant, I had to go, like the rule was you couldn't bring anybody in with you. Luckily, they allowed me to bring my husband, who's considered my caregiver. So the exception was made. So, you want to ask if they're allowed in the labor and delivery area, if they're allowed in the OR, if you're getting a C-section, if they're allowed in the recovery room, which is where you go right after surgery. And then of course, they're probably going to be allowed in the hospital room after that. In-room accessibility features. So like I said, I had a really positive experience. There was a ceiling track system with a harness so you could transfer out of bed into your wheelchair in the room they put me in. So I was really impressed by that. But It is worth asking if the hospital you choose has a room with a feature like that in the labor and delivery unit. You also want to talk about your care needs during your inpatient stay. Like, is your caregiver, if you need a caregiver, like I do, are they going to be there the whole time? And if not, will the nurses be able to attend to you and to your care needs? So one of my experiences actually that I wish I had better planned for was my husband. You know, he was really taking care of me. He helped me transfer, helped me get dressed, undressed, helped me into the bathroom, all that stuff. And I really felt that if I had asked one of the nurses to do all of that, I felt that it would have been too much to ask. I don't know if that was the reality of it or not, but I tend to hate to ask for help. But what I should have done was kind of like plan ahead and see what kind of support they have in that. My husband went back home my first night in the hospital. He needed to sleep and I needed him to sleep so he could function the next day. But the issue with that was, yeah, I did need a lot of assistance that night. And then going forward in the evenings, I needed help with the breast pump, actually, because I wanted to nurse the babies. And so, you know, you do want to ask about what kind of assistive equipment there is. If there's, you want to ask lactation consultants if there's special breast pumps that might be easier for you to use, what kind of support they can offer while you are in an inpatient, waiting for your milk to come in, and once it comes in, how they can help you manage that. You want to ask if there's a bassinet that maybe not just a bedside bassinet, but there are some that actually roll over the hospital bed. Maybe they can special order one of those for you. So these are all things you want to plan in advance. You also want to let them know what medical equipment you need, wheelchair, walker. If you need, my doctor actually had catheters ordered to the hospital, so they were there in case I forgot to bring mine or something. I don't know. I mean, it was great. Like, he thought of everything. And then finally, you also want to plan ahead for access to labor and delivery and to the NICU, especially labor and delivery. You want to have a roadmap in your brain before you go into labor. Like, you need to know where you're going, right? Especially as a wheelchair user, sometimes the routes around the hospital are a little bit more complicated, right? You have to go up and down an elevator and all kinds of stuff, whereas it might be a shorter route for if you're not a wheelchair user. Next slide. This is one of my last slides, actually. I wanted to keep this brief, but self-advocating, like Cody said, is so important. And it really takes knowing yourself first. So you need to, if you don't know yourself, you need to learn. You need to learn about your medical history. You need to pay attention to your body. Once you know these things, you need to communicate them to your providers. I think there's a mentality that patients just have to listen to what the doctor says. But when you're disabled, you really have to get the doctor to listen to what you're saying, because we tend to know, we live with this day in, day out, every second. Like, we tend to know the ins and outs, all the nuanced stuff that even a doctor can't quite understand. So self-advocating is really important, and it's okay to be firm. And I love how supportive my doctor was. And when you start your matchmaking to find the right OB for you, try to find somebody like this. So let's see if we can get this to play. This is a little soundbite. If this was him on the phone with me, because when I went into labor, he was in a different town. I was so sad, but somebody else took care of me. But this is what he said to me.
also, what I think I want to be able to do is give you the reassurance that our teams that are going to continue to care for you in the hospital overnight, because they rotate through, because nobody can stay in the hospital 24 hours. You got to go home too and sleep. I'm going to give you the reassurance that we have really good teams coming on for the weekend as well. Your particular care plan has been discussed many times at many different levels to be sure we know how to take care of you. But if you sense that anything isn't quite going the way you're expecting, just speak up. Okay. We don't see a lot of moms with the ostomy, with for the bladder. So you may have to help people kind of understand a little bit more about that. Educate our staff a little bit. We just don't see a lot of moms with that. So take the opportunity if someone is looking a little intimidated by the situation. Just let them educate them. I know that you're advocating.
Okay, so I don't know if you could hear that, but really he was just very supportive about me being a self-advocate and educating the doctors around me about what my needs were and what my conditions were, right? So, and that was great to have him like reaffirm that for me and almost like give me permission to like tell them what to do, So, so that was great. And, yeah, I mean, that actually pretty much sums up my part of things. Sorry if it was a little short, but if you guys have any questions at all. Oh, I think I have one more slide, but I think it's just a picture.
And
okay, that was when I was about 32 weeks pregnant. Again, I gave birth at 34. I don't know how I would have ever made it to 38 was when they wanted to plan to induce me. I don't know how I would have ever made it because I was pretty large there. But anyway, so if you guys have any questions, nothing's off limits. Just, go ask and yeah, look forward to answering.
Yes, if anyone has any questions, you can enter them into the Q&A function, which is at the bottom of the screen. We did have a couple of questions that were submitted in advance. And someone wanted to know, I don't know if you'll be able to speak to this, but I'll ask the question, do periods increase spasticity? Cody, could you unmute?
Can you hear me now? So for me, so I don't feel cramps, but my body still does. So it's almost kind of like I get a little restricted, kind of like a constipation feeling. My whole kind of torso just tightens. And then during my periods, I will notice my legs are more tense as well. Like I spasm more, and my stomach actually will sometimes spasm as well. It's kind of interesting. I don't know about you, Danny, like what you're.
Yeah, I get terrible spasms during my period. And also I feel cramps, but they don't feel like they used to feel before. I get confused because sometimes I think it's a bladder spasm. But I'm like, oh yeah, no, this is time of the month, so it's a cramp. But I also find that the cramp will trigger a bladder spasm on top of it. And, sometimes I'll have more urinary incontinence during my cycle.
I also noticed I do get autonomic dysreflexia because I don't feel the menstrual cramps, but my body still does. So I will get flush in the face, or goosebumps is a main sign of mine. So, or a headache, a massive headache that lasts a couple days. So yeah, good question.
Okay, then someone else wants to know, again, speaking from your personal experience, if you know of any treatment or management options for neuropathic perineum or urethral pain.
Do you know?
I don't know. I don't know. I mean, the only thing I can think of are some of the I'm not a doctor, so I can't really say, but I would think that some of the drugs that treat neuropathic pain in general would also help for that.
Yeah. Yeah, that would be something definitely to ask an OBGYN, because I mean, I do have sensation in that area, but not to the point of pain. So, I mean, and that's why, again, like kind of doing exams, like if you see redness in certain areas or swelling, you know, definitely that's why you should go and get checked every year or whatever the guideline is. I try to go every year because I am paralyzed. So that's an interesting thing. That's an interesting question. Definitely contact an OBGYN for that.
And if anyone has any final questions, they can just put them into the Q&A box again down at the bottom of your screen.
And Danny and I are also on, you know, social media, and you know, if you don't want to ask now or want to know later about something, you know, we're definitely trying to obviously advocate for women. So the more I think our little community, which is a large community, shares, and, you know, Danny's got a Facebook page that she sort of goes to. So the more we share, I think the better things hopefully we'll get. So yeah, you can all find us on social media as well.
Yeah, and I think, you know, things will get better if we hold the medical community to higher standards. So we need not be meek. You know, we should really advocate and be firm, right? About what our needs are and about what our practitioners, you know, need to step up, you know. Maybe not just individually, but maybe even, you know, med schools and need to have programs where they train more specifically about how to treat people with disabilities.
Yeah, that's definitely the biggest issue is education. There is nothing in medical school that trains, or, you know, even a course, even just a 2-week semester long, however long course on just sort of the basic disability issues. But I've learned recently that the problem also with that is that the accreditation bodies don't have any sort of testing standards for medical doctors about disability issues. So in order to address the medical education problem, there needs to be policies within the accreditation. So I hope we can change that somehow as well. But yeah, we hope it was a helpful webinar for everybody.
Well, thank you so much to you both for just very open, honest conversation and discussion, and for sharing your stories and your experiences. We really appreciate it. And it was a wonderful presentation. So very grateful to both of you for doing this for the Women's Health Series and for Women's Health Week. And I'll just let everyone know we're going to wrap up, and there will be a recording of this webinar available on the Reed Foundation's YouTube channel that will be up in the next few days. So I look for it sometime next week. Just thank our audience again for joining us. And again, a great big thanks to our presenters today. So thanks for joining us, and I hope that everyone has a really great weekend.
Thank you.
all.